Welcome to the deep dive. Today, we're tackling chronic kidney disease, CKD for short. It's often called the silent threat, right? Because it's incredibly widespread, often misunderstood, and, well, it's becoming more common, so understanding it is really critical.
Absolutely.
Our mission today is to take a whole stack of the latest medical research, the guidelines, and really pull out the most important, actionable insights about CKD for you. Make it clear, make it accessible.
Exactly. Think of this as maybe a shortcut, a way to really get your head around CKD,
Right.
what it is, who's at risk, how it's diagnosed, the staging, and really importantly, the latest ways to manage it. We want to focus on the practical stuff, the why it matters for your health.
And hopefully give you some surprising facts along the way.
Definitely some essential takeaways.
Okay, let's jump in. What exactly is chronic kidney disease? I mean, it sounds serious, but what's the official medical definition we should be working with?
Okay, so the core definition is pretty specific. It's defined by having markers of kidney damage. Think things like protein leaking into your urine or having a lower kidney function, which we measure using the glomerular filtration rate, or GFR.
GFR. Okay.
And here's the really crucial part. Either that damage or that low GFR has to be present for 3 months or more.
3 months.
Yeah, that persistence is key.
Yeah.
It's what separates CKD from maybe a temporary kidney issue. Like, if you get really dehydrated or have a short-term infection, that resolves.
I see. So it's not just a snapshot, it's a trend. Why is that time frame, the 3 months, so important for people to understand?
Well, it's vital because it confirms this isn't just a fleeting problem. It's a chronic, ongoing condition. And that changes everything, how we diagnose it, how we manage it, the prognosis.
Right.
And what's really interesting is that you can have those subtle signs of damage, like the protein in the urine we mentioned, indicating CKD. Even if your GFR, your main kidney function number, still looks relatively okay.
So damage can be happening silently before the main function drops off noticeably.
Precisely. It highlights that damage can be brewing under the surface.
That's a powerful point. So if these issues can be subtle, who really needs to be paying attention? Who's most at risk for developing CKD?
Well, the two biggest drivers, hands down, no question, are type 2 diabetes and hypertension, high blood pressure.
Okay.
They account for the vast majority of CKD cases. Diabetes is linked to somewhere between, say, 30 and 50% of all cases.
Wow.
And high blood pressure, around 27%. So if you have either of those, managing them effectively is absolutely your best defense against CKD.
That makes a lot of sense given how common both those conditions are. Let's dig a bit deeper. Beyond diabetes and high blood pressure, what are some of the other, maybe less obvious or even surprising risk factors?
Yeah, good question, because it's definitely not just those two. For instance, age is a factor. Our kidney function naturally tends to decline as we get older, especially after about age 55. And then there's genetics and family history. That can play a really significant role.
How so?
Well, there are specific inherited conditions like polycystic kidney disease, PCKD. With PCKD, a large percentage, maybe 50 to 75% of patients, could end up needing dialysis by the time they're 70.
Gosh, that's serious.
It is. And there are others too, like Alport syndrome, medullary cystic disease. These genetic factors are really important.
So some people are just sort of dealt a tougher hand genetically. What else contributes?
Absolutely. Other medical conditions definitely increase risk. Things like autoimmune diseases, systemic lupus or SLE, scleroderma. These can directly harm the kidneys.
Right, the body attacking itself.
Exactly. And even certain viral infections are implicated. HIV can cause a specific type of kidney disease, especially in people of African descent, though thankfully modern HIV treatments help a lot. Hepatitis B and C are also risk factors. And then there are more sort of structural or recurring issues, like frequent urinary tract infections or abnormalities in the urinary tract itself. Even metabolic syndrome, that cluster of issues like obesity, high blood sugar, abnormal cholesterol that's linked to.
It's quite a list. What about medications? Can things we take for other problems end up hurting our kidneys?
Oh, definitely. That's a really important one. Common painkillers, the NSAIs like ibuprofen or naproxen, they can cause acute kidney injury, especially if you're already vulnerable.
Vulnerable how?
Like if you're older or if you have existing high blood pressure or heart failure, or if you're taking diuretics. In those situations, NSAIDs can be particularly risky for acute problems.
And long-term use.
Yeah, long-term regular use of NSAIDs can also worsen existing CKD progression. There's even this historical condition, analgesic nephropathy, caused by chronic use of certain painkiller combinations, like acetaminophen and aspirin together, which slowly damage kidneys over time.
Wow. So just being aware of the medications you take regularly is key.
Crucial. Absolutely crucial.
Okay, that's a lot of potential roads leading to CKD. So if someone fits into these risk categories, how do doctors actually figure out if they have it? What are the main diagnostic tools?
Right. That's the next step. And it's definitely more than just looking at one single blood test result. We really need to assess two key things together. Kidney function, how well they're filtering, and kidney damage, are there signs of injury?
Okay, function and damage. So what are the best, most reliable tests used for screening and diagnosis?
Well, we take a kind of multifaceted approach. For overall function, the best measure is considered the glomerular filtration rate, the GFR we mentioned.
Right.
A healthy young adult might have a GFR around, say, 120 milliliters per minute.
Okay.
Now, the true gold standard test for GFR is complex and not practical day to day.
So how do you estimate it?
We use blood markers. The most common one is serum creatinine. It's a waste product from muscle, but its level can be affected by things other than kidney function.
Like what?
Like having very high or very low muscle mass, certain diets, high protein, low protein, even vegetarian or keto, and some medications can also interfere with the reading.
So creatinine gives us a clue, but it's not the whole story. Is there a better marker?
Well, there's another one called serum cystatin C. It's a protein produced by most cells in the body at a pretty constant rate, and the kidneys filter it out. So in theory, it could be a more ideal marker.
Could be.
Yeah, could be, because it also has some factors that can influence it, like smoking, body fat, inflammation, even thyroid issues or chemotherapy.
Sure.
But here's the latest thinking.
Okay.
According to the very recent KDIGO 2024 guidelines, the most accurate way to estimate GFR now is actually by using both serum creatinine and serum cystatin C together in the calculation.
Combining them.
Exactly. That combined estimate, called eGFR-CRCCs, gives a much more reliable picture of true kidney function. It helps iron out some of the individual variations of each marker alone.
That makes sense. And you mentioned something earlier about race in these calculations.
Yes, that's a really important point. Historically, some GFR estimation equations included race as a variable. However, there's strong evidence now that this could overestimate kidney function in Black individuals, potentially delaying diagnosis or referral.
Leading to disparities in care.
Precisely. So these race-based adjustments are being actively removed and reevaluated to ensure the calculations are fair and accurate for everyone.
Good. That's a crucial development. Okay, so that covers estimating kidney function. What about detecting the damage part?
Right. The other piece of the puzzle, the primary way we look for ongoing kidney damage is by checking for protein in the urine, specifically albumin. This is called albuminuria.
Albuminuria.
And it's often the earliest and, frankly, the best marker that something is wrong, that there's ongoing damage. Even small, persistent amounts of albumin leaking out.
Even if the GFR is still okay.
Yes, even then. What we call moderately increased albuminuria, it used to be called microalbuminuria, is a significant red flag. It's strongly linked to a higher risk of heart attacks, strokes, heart failure, and even death, completely independent of the GFR level.
Wow. So the leak itself is a major risk factor. How do you test for that accurately?
The best way is a simple spot urine test called the urine albumin creatinine ratio, or UACR. It's much more sensitive and specific than just a basic urine dipstick test, and it gives us a number we can track over time.
Okay, UACR. What's considered normal?
Normal is less than 30 milligrams of albumin per gram of creatinine, so anything persistently above that needs attention. We sometimes also use a urine protein creatinine ratio, or UPCR, and occasionally a 24-hour urine collection, but the UACR is usually the go-to screening test.
Got it. But you mentioned temporary protein earlier?
Right. Important clarification. Not all protein in the urine means CKD. You can get transient temporary proteinuria after really intense exercise, or if you have a fever, sometimes just from standing up for a long time, dehydration, or a urinary tract infection. That doesn't signify chronic kidney damage. It needs to be persistent.
Okay, persistent albuminuria via UACR and estimated GFR using both creatinine and cystatin C, those are the key diagnostic pieces.
Primarily, yes. We also look at urine sediment sometimes for blood cells or casts, and imaging like ultrasound can show if kidneys are shrunken or scarred, suggesting chronic disease. But GFR and albuminuria are the core components for diagnosis and staging.
Staging. Okay, so once CKD is diagnosed using these tools, how does all that information come together? How do doctors classify how advanced it is and use that to guide care?
That's where the KDIGO classification grid is incredibly useful. It's not just a stage number. It's more like a risk map.
A risk map. How does it work?
It cleverly combines both the GFR category, which ranges from G1, meaning normal or high GFR, down to G5, which signifies kidney failure with a GFR less than 15, and the albuminuria category, A1 for normal, mildly increased, A2 for moderately increased, and A3 for severely increased albumin.
So you plot those two things on a grid.
Exactly. You find where a patient falls based on both their GFR and their albumin level. And the grid is usually color-coded to show risk level: green for low risk, yellow, orange, red for progressively higher risk.
And what's the big insight from looking at it that way?
The really crucial aha moment from this grid is seeing how much the albuminuria level impacts risk, even within the same GFR category. Meaning someone with a relatively decent GFR, say in the G2 or G3A range, but who has severe albuminuria A3, might actually be at higher risk for complications like heart disease, progression to kidney failure, and death than someone with a lower GFR but no albuminuria A1.
So that protein leak, the Bammage marker, is a massive risk multiplier, independent of the filtration rate itself.
Precisely. It hammers home that CKD isn't just about how well the kidneys filter. The ongoing damage indicated by albuminuria is a critical driver of bad outcomes, especially cardiovascular ones.
That's a really important distinction. So this staging isn't just a label, it's, like you said, a dynamic roadmap for risk. How does this detailed staging influence decisions, like when to send someone to a kidney specialist, a nephrologist, or when to start thinking about dialysis?
It's the primary guide for those decisions. For instance, clear triggers for referring to a nephrologist include progressing to stage 4 or 5 CKD. That's when GFR drops below 30, technically below 29.
Okay.
Also, a rapid decline in kidney function is a major red flag. If someone's eGFR drops by more than 5 points per year or takes a significant dip like more than 20 or 30%, especially after starting certain meds, that needs specialist evaluation quickly.
What else triggers a referral?
Very high levels of albuminuria, like a UACR consistently over 300 or a UPCR over 500 that warrants referral. Persistent blood in the urine, especially with casts, is another reason. Also, hypertension that's really difficult to control despite multiple medications, or persistent electrolyte problems like high potassium or acidosis.
So specific thresholds and rates of change.
Yes, and also things like known hereditary kidney diseases or recurrent kidney stones. Plus, we now have validated CKD risk calculators. These can estimate, say, your 5-year risk of progressing to kidney failure. If that risk is moderately high, like 3–5%, that's often a reason for referral. If it's very high, like over 40% risk within 2 years, that signals it's time to seriously start planning for kidney replacement therapy like dialysis or transplant.
It sounds like this system allows for much more proactive management.
That's exactly the goal. Identify higher-risk patients earlier and get them the specialized care they need before a crisis hits.
Okay, so knowing the risks, the diagnosis, the staging, let's talk about preventing progression. What are the best strategies, especially with medications, to slow down CKD once it's diagnosed? What's new and effective?
Preventing or slowing progression is absolutely central to CKD management, and the first step, really foundational, is aggressive blood pressure control. For most people with CKD, the target systolic blood pressure, the top number, is less than 120 mmHg.
Less than 120, that's quite tight.
It is tighter than the general population guidelines because blood pressure control is so crucial for kidney protection. Beyond that, the latest KDIGO guidelines highlight 4 main classes of medications that are really cornerstone therapies for slowing CKD progression, particularly when albuminuria is present.
4 key classes, what are they?
Okay, first up, we have the ACE inhibitors like lisinopril, ramipril, and the ARBs, valsartan. These have been mainstays for a while, and for good reason. They are considered first-line therapy for essentially all patients with CKD who have any level of albuminuria, even just mildly increased, regardless of whether they have diabetes or not.
So pretty much anyone with CKD and protein in their urine should be on one?
Generally, yes. And the goal is to push the dose up to the maximum level the patient can tolerate, because that provides the best kidney protection.
What about that initial dip in GFR some people get when they start these?
Yes. That's a common concern, but often misunderstood. A decrease in eGFR of up to 30% within the first 2 to 4 weeks after starting an ACE inhibitor or ARB is actually considered acceptable in most cases. It's usually due to changes in blood flow within the kidney and is not typically a reason to stop the medication.
So you stick with it.
You stick with it. These drugs are protective long-term. We even continue them if the GFR drops below 30, as long as they're tolerated. And if side effects like high potassium hyperkalemia occur, the first step is usually dietary changes or other potassium-lowering strategies, not stopping the ACE or ARB if we can avoid it.
Okay. One more thing on these, can you use them together?
Absolutely not. That's a critical point. Never use an ACE inhibitor and an ARB in combination. It increases risks, especially hyperkalemia and acute kidney injury, without adding significant benefit. Choose one or the other.
Got it. One or the other, max dose tolerated. What's the second class?
The second class is a newer group called nonsteroidal mineralocorticoid receptor antagonists, or nonsteroidal MRAs. The main one here is finerenone.
Finerenone.
Right. These are typically considered as an add-on therapy, specifically for patients who have CKD, type 2 diabetes, and persistent albuminuria after they're already on the maximum tolerated dose of an ACE inhibitor, or ARB. And their eGFR generally needs to be above 25 to start it.
So an extra layer of protection for a specific group.
Exactly. It offers additional kidney and cardiovascular benefits in that population.
Okay. And the third class, you mentioned this one was a big deal.
Yes, the third class has really been a game changer. The sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors, drugs like empagliflozin, dapagliflozin, canagliflozin.
The ones originally for diabetes.
That's right. They started as diabetes drugs, lowering blood sugar by making you pee out excess glucose. But clinical trials showed they have powerful protective effects on the kidneys and heart, even in people without diabetes.
That's fascinating. So who gets these now for CKD?
It's become quite broad. They're recommended for patients with type 2 diabetes and CKD, pretty much regardless of albuminuria level. They're also recommended for patients with heart failure and CKD.
Okay.
And importantly, for people without diabetes, they're recommended if your eGFR is between 20 and 45, again, regardless of albuminuria. Or if your eGFR is higher than 45, but you have significant albuminuria, specifically a UACR over 200.
So a really wide range of CKD patients can benefit.
A very wide range. They significantly reduce the risk of CKD progression, kidney failure, cardiovascular events, and death. There are some limits. They generally shouldn't be started if the eGFR is already below 20.
But if you're on one and your GFR drops below 20 later,
then you can usually continue it, unless there are tolerance issues or dialysis is started. The benefits often persist even at lower GFRs.
incredible. ACE-ARBs, nonsteroidal MRAs, and SGLT2 inhibitors. That's 3. What's the fourth class?
The fourth isn't a single class, but rather highlights the importance of other supportive medications, primarily diuretics.
Water pills.
Exactly. Both thiazide diuretics and loop diuretics can be really helpful for managing blood pressure and fluid overload in CKD. Plus, they can sometimes enhance the protein-lowering effects of ACEs or ARBs when used together. Interestingly, studies have shown drugs like clothalidone can still be effective even in advanced stage 4 CKD, although you need careful monitoring.
Okay. Any other notable drug types?
Well, calcium channel blockers, CCBs, are commonly used for hypertension, but not all are equal when it comes to protein in the urine. The non-dihydropyridine types, like verapamil and diltiazem, might actually help reduce proteinuria, whereas the dihydropyridines like amlodipine or nifedipine generally don't have that extra benefit, though they still lower blood pressure.
So a preference for certain CCBs if proteinuria is an issue.
Potentially, yes, though the evidence isn't as strong as for the first 3 classes we discussed. The core strategy really revolves around maximizing ACE-ARBs, adding an SGLT2 inhibitor for most eligible patients, and considering a nonsteroidal MRA in the specific diabetic population.
It sounds like these medications aren't just passively managing symptoms, they're actively working to protect the kidneys and slow down the disease itself.
That's precisely the shift in thinking. We now have multiple drug classes proven to modify the course of CKD progression.
That's huge progress. But CKD affects more than just the kidneys, right? What about the other complications that often pop up as the disease advances?
Absolutely. As kidney function declines, CKD becomes a truly systemic condition. Beyond just trying to slow the GFR decline, a huge part of management is tackling the common complications. Things like anemia, tricky nutritional needs, and really complex disturbances in mineral and bone metabolism. These often significantly impact how someone feels day to day.
Let's start with anemia. That's often linked to fatigue, low energy, right? How does CKD cause that, and what can we do?
Right. Healthy kidneys produce a vital hormone called erythropoietin, EPO. EPO signals your bone marrow to make red blood cells.
Okay.
In CKD, especially as it advances, the damaged kidneys don't make enough EPO. Less EPO means fewer red blood cells, and that leads to anemia.
Makes sense. When do you start looking for it?
We typically start screening for anemia once someone's GFR drops into category G3A, so below 60. And we define anemia usually as hemoglobin below 13.5 in males or below 12 in females. But critically, anemia CKD is often a diagnosis of exclusion.
Meaning you rule out other causes first.
Exactly. Before blaming CKD, you have to thoroughly check for other common causes, especially iron deficiency, which is very frequent in CKD patients too, and also things like B12 or folate deficiency.
Okay, so once other causes are ruled out or treated, what about treating the CKD-related anemia itself?
That's where erythropoiesis-stimulating agents, or ESAs, come in. These are basically manufactured versions of EPO. They're approved to treat symptomatic anemia in CKD patients, typically when hemoglobin levels fall below 10 GDL.
So they boost red blood cell production. Do they help overall outcomes?
That's the crucial caveat. While ESAs can definitely improve symptoms like fatigue and energy levels, studies have shown they do not improve survival. In fact, aiming for higher hemoglobin levels with ESAs is associated with increased risks of serious cardiovascular events, stroke, and even death.
Wow. So more isn't better here.
Definitely not. It's a very careful balancing act.
Yeah.
The FDA recommends using the lowest ESA dose needed to reduce the need for blood transfusions and to reduce the dose or hold it if hemoglobin goes above 10 or rises too quickly. We aim to manage symptoms, not necessarily normalize the hemoglobin number.
That's a really important distinction for patients to understand. Okay, moving from anemia to diet. This seems like a minefield, so much conflicting information out there for kidney patients. What are the key dietary adjustments doctors recommend and why?
Diet is absolutely fundamental in CKD management, but you're right, it can be confusing. It really requires personalization and ideally guidance from a renal dietitian. But let's cover the main areas. First, protein.
Yeah, always a big topic, more or less.
Well, the latest KDI Go guidelines actually suggest maintaining a normal protein intake for most adults with G3, G5 CKD around 0.8 grams per kilogram of body weight per day. That's similar to the general population.
So not automatically restricting protein.
Not automatically, no. However, if someone is considered at high risk for CKD progression, they should avoid high protein intake, maybe keeping it below 1.3 G kg day. Very low protein diets like 0.3, 0.4 G kilograms are sometimes used in advanced CKD under very close supervision with a nephrologist and dietitian, but there's a significant risk of malnutrition, so it's not a general recommendation.
And what kind of protein? Doesn't matter.
There's growing evidence suggesting that plant-based proteins might be preferable. They seem to generate less acid load and potentially put less stress on the kidneys compared to animal-based proteins.
It's interesting. Okay, what about sodium?
Sodium restriction is key. The standard recommendation is less than 2 grams of sodium per day, which is less than 5 grams of salt, sodium chloride.
Why is that so important?
It helps lower blood pressure, which is crucial. It can also help decrease the amount of albumin leaking into the urine, and it's vital for managing fluid overload and swelling.
Makes sense. What about potassium? Everyone seems worried about potassium and kidney disease.
Yeah, potassium gets a lot of attention. But here's the thing. There are no universal potassium restriction recommendations for all CKD patients. Restriction is only needed if someone actually develops hyperkalemia, meaning high potassium levels in their blood.
So you only restrict it if it's high?
Correct. And even then, if hyperkalemia occurs, restricting dietary potassium isn't the first step. First, we look for and treat other contributing factors, like metabolic acidosis, or adjust other medications that might be raising potassium, not the ACE inhibitors, or ARBs, usually. We might add diuretics. Dietary changes come after that. We try very hard not to reduce or stop those kidney-protective ACEs, ARBs, or MRAs just because of mild or moderate hyperkalemia, because those drugs are so beneficial long-term.
That's a really important hierarchy. Save the key drugs if possible. You mentioned metabolic acidosis.
Yes. As kidneys fail, they can't get rid of acid properly, so the blood becomes acidic. If serum bicarbonate levels drop too low, typically below 22, treatment with alkali supplement, usually sodium bicarbonate tablets, is recommended. Correcting acidosis can actually help slow CKD progression, and it also helps prevent potassium from getting too high and can protect bones.
Okay. And finally, phosphorus and calcium. These seem complicated too.
They are, and they tie into bone health. For phosphorus, if levels in the blood go above 4.6 milli-GDL, restriction is recommended, aiming for around 800 to 1,000 milligrams per day.
What foods are high in phosphorus?
Dairy products, nuts, seeds, beans, whole grains. But the biggest culprits are often processed foods because they have phosphate additives used as preservatives, which are very easily absorbed. Reading labels is key.
And calcium.
For calcium, the main goal is limiting total intake to less than 2,000 milligrams per day. This includes calcium from diet and from any calcium-based phosphate binders someone might be taking. We'll get to binders in a moment.
Okay, that covers the main dietary pillars. Moderate protein, low sodium, potassium only if high, manage acidosis, and watch phosphorus and calcium. Seems like a lot to juggle.
It is. That's why working with a dietitian specializing in kidney disease is so valuable.
Absolutely. Now, you mentioned phosphorus and calcium tie into bone health. Let's talk about that mineral bone disorder, or MBD. What is it?
Right, CKD mineral and bone disorder, CKD-MBD, is a really common and complex complication. It starts developing as GFR falls below 60. Essentially, the kidneys lose their ability to get rid of excess phosphorus and, crucially, to activate vitamin D.
Okay. How does that cause problems?
Well, the high phosphorus and the lack of active vitamin D lead to low calcium levels in the blood. The body senses this low calcium and tells the parathyroid glands, small glands in your neck, to pump out more parathyroid hormone, or IPTH.
Trying to fix the calcium level.
Exactly. IPTH tries to raise calcium by pulling it from bones and increasing phosphorus excretion. But in CKD, the kidneys can't respond properly, so phosphorus stays high, calcium stays low or normal, and IPTH just keeps getting higher and higher. This whole cascade messes up bone turnover and can lead to weak bones, fractures, and also calcification of blood vessels.
So it's a vicious cycle affecting bones and blood vessels. How do you monitor MBD?
We regularly check serum levels of calcium, phosphorus, IPTH, and also 25-hydroxyvitamin D. That's the storage form of vitamin D. We track these typically starting in stage 3 CKD.
Let's break down the management. What about vitamin D?
Okay, so the kidneys normally convert that storage 25-OH vitamin D into the active form, 1025-dihydroxyvitamin D, or calcitriol. In CKD, this conversion process fails.
Right.
So first, we check the storage levels, 25-OHD. If they're low, say below 20 NG-ALEA, we recommend repletion with standard vitamin D supplements, like ergocalciferol D2 or cholecalciferol D3, just like in the general population. Getting the storage levels up is the first step.
Okay, replenish the stores. What if IPTH is high?
If IPTH is elevated, the first thing we do is make sure their vitamin D stores are adequate and that their phosphorus isn't too high. Often correcting those underlying issues will bring the IPTH down.
So you treat the cause first.
Always. We generally don't treat elevated IPTH directly just because the number is high, especially in earlier stages. The ideal IPTH level in CKD is actually unknown. Direct treatment targeting IPTH, like using active vitamin D analogs or other drugs, is usually reserved for severe hyperparathyroidism in later stages, stage 4 or 5, and typically managed by a nephrologist.
Got it. What about managing the high phosphorus directly?
Managing high phosphorus is critical because it's strongly linked to increased mortality. The first line is dietary restriction, focusing heavily on avoiding those phosphate additives in processed foods.
And if diet isn't enough?
Then we use phosphate binders. These are medications taken with meals that bind to phosphorus in the gut, preventing it from being absorbed into the bloodstream.
Are there different types?
Yes, there are calcium-based binders like calcium carbonate or calcium acetate, and non-calcium-based binders like sevelamer or lanthanum. Generally, the non-calcium-based binders are preferred, especially if calcium levels are normal or high, because there's concern that adding extra calcium with binders might contribute to vascular calcification.
So prefer non-calcium binders if possible, and managing calcium itself.
The main goal with calcium is simply to avoid hypercalcemia, high calcium levels. Mild, asymptomatic low calcium often isn't treated aggressively. If calcium is high, we need to figure out why. Could it be too much vitamin D supplement, calcium binders, or even another underlying issue?
It sounds incredibly complex, balancing all these minerals and hormones.
It really is. Especially in stages 4 and 5 CKD, managing MBD effectively requires very close monitoring and collaboration between the patient, dietitian, and nephrologist. It also involves assessing bone health itself, sometimes using DXA scans. But the gold standard to know exactly what kind of bone disease is present is actually a bone biopsy, though that's not done routinely.
Wow, okay. This deep dive has covered so much ground definition, risks, diagnosis, staging, the latest medications, and these complex complications like anemia and MBD. This information feels absolutely vital. If you had to boil it down, what's the single biggest takeaway for someone listening who might be at risk or knows someone with CKD?
I think the biggest takeaway is that while CKD is definitely serious and progressive, it's absolutely not a hopeless diagnosis. With early detection, knowing your risks, getting screened regularly if you're at risk, and then applying these comprehensive management strategies we've talked about.
The medications, the diet, managing complications.
Just exactly. With that proactive, patient-centered approach, we can significantly slow down the progression of CKD for many people. We can maintain quality of life, delay, or even prevent the need for dialysis. The key is understanding the whole picture, not just one lab value, and acting on it early and consistently.
So what does this all mean for you, the listener? If you fall into those risk categories, diabetes, high blood pressure, family history, or if you know someone navigating CKD, hopefully this deep dive highlights just how critical regular screening and proactive informed management really are. It's about understanding how these body systems are linked and empowering yourself or supporting someone else with this knowledge. And that leads to a final thought for you to maybe mull over after listening. We've seen today how deeply interconnected things are with CKD, how it ripples out to affect blood pressure, blood cells, bones, the heart. Considering that, what other common health conditions might have equally widespread, maybe surprising ripple effects throughout the body that we perhaps tend to overlook, maybe until things get more serious? It's something to think about.